Over to you, sir. Please introduce our speaker.
Our next topic is secondary hypertension, and speaker is none other than Dr. Arindam Pandey, who is well-known interventional cardiologist at Medica Hospital. So, stage is yours, Dr. Pandey.
Can make good amount of difference in the mortality of the patient, but the problem in our country only, screen trial may not be replicated due to very reasons. But now this was actually discussed in this year's BSc.
Running? Okay, fine. So this was discussed in this year's ESC, European Society of Cardiology, the burden of cardiovascular event occurring among individuals with elevated blood pressure. So you all know how blood pressure, systolic blood pressure beyond 140 is bad, but what about the blood pressure in between 115 and 40? Is it good for our population? Answer is no. There had been clear-cut evidence which suggests that even this high or elevated blood pressure, which we do not consider to be ideal for pharmacotherapy, is not good for our population, and we should actually do something, at least lifestyle modification, intensive lifestyle modification. If that is not successful, then probably we can plan pharmacotherapy if the patient is young, because this mild kind of elevation of blood pressure, if that is there for a long duration of time, which typically happens in our younger population, is going to play havoc in the long-term outcome of our patient, and that is the reason why our population, Indian population, have so many high number of cerebrovascular accidents. Now, why hypertension happens? What is the pathophysiology? Now, there are important pathophysiology which is actually similar for both primary and secondary hypertension. We all know it is the blood pressure regulation which is hampered in all hypertensive individual. So how the blood pressure is regulated? We know the role of renin, angiotensin, and aldosterone axis. We know the role of sympathetic nervous system. Those are important. Now, if this regulation becomes impaired, then the blood pressure gets elevated. There is important role played by environmental factors. We all know the role of pollution, particularly sound pollution, has very clear relation with the high blood pressure. Lifestyle factor, we by this time very clear, our food habit, our sedentary lifestyle, obesity, everything plays very important role, and we should not forget about the genetic factor. Genetic factor probably is the most important factor, particularly in essential hypertension, which is actually directly related to the genetic of the population. So let us start with a case. Now this particular gentleman is a 36-year-old male who came with chief complaint of early morning headache. So that is the only solitary complaint of the patient, early morning headache. On evaluation, it was found that he is not a known, diabetic, cholesterols are normal, non-smoker. If you see the body weight, BMI is 24. So probably we cannot categorize this particular gentleman as obese individual. So general examination, blood pressure is 180 by 110. Is it common? Yes. In our country, this kind of young people, many a time we get this kind of blood pressure. Patient was already on telmisartan 40 milligram, but in spite of the fact, the blood pressure was 180 by 110. On further evaluation, it was found that he had a little short neck, little short neck. So as the patient is 36 years, extensive evaluation, renal Doppler, abdominal ultrasonography, nothing was found. We also, did renin aldosterone test. We also went for urinary 24-hour urinary metanephrine. Everything came to be normal. So what may be the reason? Is it the premature accelerated the essential hypertension, secondary hypertension? Now on further evaluation, there was a clue on a physical examination. He had a short neck. Generally, a very important cause of secondary hypertension in today's era is obstructive sleep apnea. We generally tend to evaluate patients on the basis of history, physique, particularly in obese individual. But we should not forget this obstructive sleep apnea may affect even the normal weight individual. So he was evaluated for obstructive sleep apnea, and it was found that his AHI index is 74. That indicates he was suffering from severe obstructive sleep apnea. Now, how to go ahead? Yes, to control the blood pressure, probably we need to adjust the pharmacotherapy. At the same time, we should apply other lifestyle measure to improve the outcome. At the same time, CPAP therapy is indicated. But again, there may be debate whether CPAP therapy will improve the mortality of the patient. Answer is no, because as of now, we do not have any evidence which suggests that applying CPAP, even with patients who are having high blood pressure, which is not properly controlled with pharmacotherapy, do not change any mortality outcome of the patient. But yes, to control the blood pressure in this kind of situation, apart from adjustment of pharmacotherapy, CPAP is essential, because if you do not apply CPAP, your blood pressure is not going to come under control. So accordingly, CPAP was initiated. Lifestyle modification was further, supported. Now, as I was supposed to talk on secondary hypertension. Secondary hypertension, many a time we do not discuss much because it is not very much endorsed by the industry, because niche population. Mostly it is the primary hypertension, essential hypertension. Secondary form of hypertension account for only small fraction of overall hypertension prevalence, which largely, mostly it is the primary hypertension. Now, secondary hypertension is not precisely known what is the exact definition, because available data may be confounded by the selection bias of the studies reported in literature, number of undiagnosed cases, and varying definition of secondary form of hypertension. So we are not very sure what is the prevalence. How many patients in India are actually having secondary hypertension? If you ask me the question, I don't have any answer. So despite secondary hypertension, limited prevalence, detection and management, it is utmost important. Why? Because if you can detect someone with secondary hypertension, you have a solution for the patient, because in future, if you treat the primary problem, the blood pressure lowering agent or pharmacotherapy may completely be omitted in some of the patients. So that is a huge thing. So that is why probably secondary hypertension, though it is not very common, we should have a strong suspicion. Fine. Now, when to suspect secondary hypertension? So yes, in younger individual, age less than 40 years, if someone comes to your chamber, you should suspect. But if you see the available, whatever data we are having, even in younger individual who comes to your clinic with high blood pressure, what is the commonest cause of high blood pressure? It is not the secondary hypertension. Even in young population, it is the primary hypertension, which is the commonest cause of hypertension. But there should be an additional suspicion. So young patient, yes, you need to, look for it, the signs of secondary hypertension. If you find, sudden hypertension, which was pretty well controlled 2-3 months back, but now it is somehow not controlled with usual medication, you should have a suspicion. Hypertensive emergency, resistant hypertension, unexplained end organ damage, these are the cases you should have suspicion. Yes, if you have additional endocrinal features, manifestations, you should also have a strong suspicion. So, this is the incidence of selected form of secondary hypertension according to age. You can see, as per the age, the prevalence and the etiology of secondary hypertension that gets deviated. So, mid-aortic syndrome, coarctation of aorta, very important cause of coarctation in young individual. Renovascular hypertension, it is equally common in young as well as in adult, but the etiology changes. If a young person comes to you with renovascular hypertension, it is the fibromuscular dysplasia which has to be evaluated. But in similar kind of renovascular hypertension, which is equally important, an important cause of secondary hypertension in elderly population, there is atherosclerotic renovascular disease is the cause of this secondary hypertension. CKD or chronic renal parenchymal disease is important cause across the age. Now, there are some monogenic disorder, some endocrinal problem, Cushing syndrome, pheochromocytoma, paraganglionoma, many a time we discuss a lot of things about this, but they are not very common. They are not very common. You should have that in suspicion range, but it is not very common. Primary hyperaldosteronism as well as secondary forms of hyperaldosteronism are rather more important and more prevalent causes of secondary hypertension. So that is how it goes. So few words regarding the different important types of secondary hypertension. Atherosclerotic, I must say that cardiovascular phenotype, if you see on the left-hand panel, all the patient will have, resistant hypertension and 24 ABPM ambulatory blood pressure monitoring, frequent non-dipping pattern, and left ventricular hypertrophy, which is otherwise not explained by the level of blood pressure or office blood pressure. So decreased diastolic function, so increased cardiovascular risk and mortality. These are actually identical for all the secondary hypertension patients. So left-hand side is almost similar. But if you see the right-hand side, you can see it is quite prevalent. So prevalence is 6 to 14%, mostly in elderly population. Very important cause of secondary hypertension in elderly population. So how do you screen? Yes, initially you are supposed to do a simple Doppler, which is not very expensive. But if you have a very strong suspicion, you can go ahead with CT angiogram, which can actually clinch the diagnosis and give a gold standard of diagnosis. Now, how you are supposed to treat? Yes, pharmacotherapy will be there, but at the same time, some patient will benefit, some selected patient will benefit from intervention. Fine? So it is not widespread, routinely advised to everybody, but some patient actually can benefit. Similarly, the same kind of renovascular hypertension, if you find it in younger individual, it is the fibromuscular dysplasia, which is not very uncommon. Again, similar kind of screening, but you can see there are some difference because other arteries are also involved. In fibromuscular dysplasia, not only the renal artery, other arteries are also involved. So here, you can also go for, apart from pharmacotherapy, some intervention, but here it is said that, routine renal angioplasty with use of stent is not recommended. Nowadays, emerging data suggests simple balloon angioplasty. In this kind of patient, renal balloon angioplasty, even there are trials, ongoing trials, drug-coated balloon angioplasty for this kind of young patient can be a very good solution. Fine. Now, primary aldosterone, how do you actually suspect? You get a patient of blood pressure, high blood pressure. You have a suspicion of secondary hypertension. Suddenly you find the potassium is chronically keeping on the lower side. A very subtle sign on the routine investigation. You should have that on mind, because this is a treatable cause of secondary hypertension. You should go ahead, you can choose a properly done CT or MR. Nowadays MR has also emerged as a very important diagnostic tool, and if you can detect it, a surgical intervention can actually result in altogether stoppage of all blood pressure medication. Or if it is bilaterally involved, then actually you can properly target your pharmacotherapy in this kind of situation. So very important cause, pheochromocytoma, paraganglioma, yes, 24-hour free urine metanephrine, you should, but there are subtle signs. It's not very common, but if you get a flushing, high fluctuation, episodic hypertension, you should have that in mind. You should evaluate, and there is a treatment for this kind of situation. Very important. Cushing syndrome, typical phenotype, you can have it. It is not very difficult to diagnose. Captopril suppression test, little tricky, but I don't see people are doing it. Rather, overnight 1 milligram dexamethasone suppression test. It's very easy to do investigation, and you can clinch the diagnosis, and you can target your therapy. So the requirement of other antihypertensive actually comes down. So I'm not going to detail of other secondary form of hypertension. Let us discuss about how you're supposed to treat, because even in secondary hypertension, reduction of blood pressure is important. Now this is the 2024 recently concluded European Society of Cardiology algorithm. So how you're supposed to approach any patient comes to you with high blood pressure. Is there any role of monotherapy? Still, I'll show you some data for our Indian data. Monotherapy, as per the guideline of European Society of Cardiology, they have very selected role of monotherapy. They have clearly mentioned elevated blood pressure category in the borderline. You can go ahead with one pill treatment, moderate to severe frailty. Frailty nowadays is very commonly discussed thing in many of the conferences. Symptomatic orthostatic hypotension. So permissible hypertension. You use only single pill and you can actually permit some amount of hypertension. If the patient's age is more than 85 years, these are the four situations. the European Society of Cardiology clearly mentioned that you can go ahead with monotherapy, single pill treatment of hypertension. In all other situations, it is the low-dose combination pill for all patients of hypertension who requires any form of pharmacological intervention. So if that is not controlled, you are supposed to check the blood pressure after 1 to 3 months. If it is not controlled, you can increase the high-dose combination of two molecule. If it is controlled, fine. If it is not controlled, you can go ahead with low-dose combination of 3 drugs. You can see the pill remains single. Even from the monotherapy, low-dose combination, high-dose combination of double drug, triple drug combination, again single pill. If it is not controlled, triple drug combination of higher doses of individual molecule. If that, then also it is not controlled, and one of the molecule is diuretic, by definition, your patient is suffering from resistant hypertension. What you are supposed to do in resistant hypertension, you should have a strong suspicion of secondary form of hypertension, which I just discussed, and then you should also check pseudo-resistant hypertension. Many a time, the patient is not taking the pill. That is why all the recommendation bodies, big bodies, society, everybody is saying you should use only one pill for hypertension treatment, not multiple. You can see up to the stage of resistant hypertension, it is a single pill therapy. Why? To improve the compliance of the patient. Again, at this point, you should meticulously check the compliance of the patient, because many of these resistant hypertension are actually pseudo-resistant hypertension. Now, if you find the patient is taking the medicine appropriately, still it is not controlled, then you are supposed to use a molecule known as spironolactone. You can argue, why not eplerenone? Because from our experience, we know eplerenone is a good molecule, the side effect profiles are better, but you can have the mention of the molecule spironolactone at this stage, because that is much more effective in overall control of resistant hypertension. Fine. If spironolactone failed, I think there was one more slide. If spironolactone failed, you can actually go for molecules which are less commonly used. Say, for example, central sympatholytic agent, directly acting alpha blocker. So those are the medicine. And if the beta blocker was not used up to the stage of addition of spironolactone, you can think about adding beta blocker at this stage. So beta blocker, is it a first-line therapy? Yes, it is a first-line therapy, they have clearly mentioned, but if you see the evidence, why beta blocker was not considered as first-line, not because of the inferior blood pressure lowering, but because of inferior efficacy in some of the trials. But we should clearly remember, those trials were done with atenolol, which is an older generation beta blocker, less than 24-hour action. So if you consider the latest generation beta blocker, they will be equally effective even in reduction of events. So more detail, I think I should skip the timing of blood pressure medicine, because there was some controversy, debate regarding at what time the blood pressure medicine has to be given. So a big trial, time trial in 2023 European Society of Cardiology has cleared the doubt. They have clearly mentioned it is not important at what time you are giving the medicine. You should give it a single time every day. That is rather more important, and you should try to use a molecule which is long-acting, at least 24-hour action. So the requirement of the molecule to be given at night, at morning is not at all important. You can give it as per the convenience of the patient. Now, regarding few more things, I think I should briefly go with this, trial. This is the Indian Hypertension Control Initiative, early outcome in 26 districts. This is a big, population level trial which is going on. You can see how the approach is very simple here. You add, I mentioned European Society of Cardiology, they have clearly mentioned low-dose combination of any two antihypertensive regime to be the first agent. But as per this protocol, you can see they are suggesting to use amlodipine 5 milligram at the beginning. If not controlled, telmisartan 40 milligram, increase to telmisartan 80 milligram. If not controlled, increase to amlodipine 10 milligram. If not controlled, add a chlorthalidone at a dose of 12.5. If it is not yet controlled, then it is supposed to be increased to the 25 milligram. A very simple algorithm. It can be followed by every primary care physician. And this was actually very, well-structured study. And it was awarded, many places it was awarded to a very nicely conducted trial, and we have initial result. We have results from Maharashtra and Punjab, which was published 2024. It showed that 70% of our population, their blood pressure gets controlled by using only 5 milligram of amlodipine. So every recommendation, societal, things are important, but we should also use our wisdom. Because from our clinical experience, we know many of the patients who comes to you with high blood pressure, just addition of simple 5 milligram amlodipine serves the purpose, and this data suggests the same. 70% of population can reach to their blood pressure goal by using a very low-cost molecule, 5 milligram of amlodipine, and that is effective. If it is not controlled, yes, you have option of adding, second line, the sartan, telmisartan probably is best. There had been evidence combination of amlodipine with other sartan, which has significantly reduced the MACE. In fact, I was also part of a consensus statement which suggested initial combination therapy in patient whose blood pressure is beyond 140 with amlodipine plus telmisartan is a very, very effective way, and that can sort the problem in majority of our population, because our population, our hypertensive population, the prevalence in India is 25% to 30% in adult. So it's a huge population. I am not sure how many of the patients they are going to come to a physician's chamber. So mostly they will go to a primary physician, and they are not going to come for follow-up. So if you have a robust trial which suggests either 5 milligram of amlodipine or a combination of 5 milligram amlodipine plus 40 milligram of telmisartan, you just give it and the blood pressure is controlled, you will serve a huge thing to the mankind, huge thing for the population of India. So calcium channel blocker, the issue of edema, it is dose related. We should keep it in mind. There are two things, important. One is it is dose related. Higher the dose of, calcium channel blocker amlodipine, higher the chance of, pedal edema. At the same time, pedal edema can appear at any point in the therapeutic window. It can appear after 7 days. It can appear after 1 year. It can appear even after 5 years. So that is a very negligible, but yes, it is dose dependent. Sometimes changing it to other calcium channel blocker may serve. Addition of ARB with amlodipine also serve, but addition of diuretic is ineffective. That we should clearly, take in mind. So European Society 2024 guideline, every place they have recommended this calcium channel blocker, particularly dihydropyridine calcium channel blocker as the initial therapy. So you can see even in diabetic individual, metabolic syndrome, chronic kidney disease, even with proteinuria and albuminuria, it is the calcium channel blocker, particularly dihydropyridine calcium channel blocker as the first choice, where you are not supposed to use it. Post-myocardial infarction, atrial fibrillation, and heart failure, these are the three situations where calcium channel blocker is not your first choice. In all other situations, you actually can use it. So coming back to resistant hypertension, this is probably my last slide. So I mentioned some patients will benefit from referral to higher center which are equipped with treatment of hypertension. Now spironolactone, if it is not controlled, you are supposed to use beta blocker. If it is not already utilized, then you have option of adding alpha blocker, centrally acting BP lowering drug, potassium sparing diuretic, and other newer therapy. But at the same time, you can see renal denervation therapy has become a class 2B indication, particularly in this group of patients. So what is the indication of renal denervation therapy? It is an expensive therapy as of now, but cost has come down significantly. But you can utilize if the patient's blood pressure is not controlled with appropriate maximally tolerated doses of 3 antihypertensive medication. Mind it, it may or may not include a diuretic. The patient is a candidate if the eGFR is more than 45. He is a candidate for renal denervation therapy if the patient is willing to go ahead. So this is a new therapy which has come out. Now we have recommendation as well, class 2B indication. So some of your patients might actually benefit out of it. Thank you very much.
Fantastic presentation, Dr. Pandey. So if there is any question from floor. May I ask a question? Hyperthyroidism and hypothyroidism both are associated with as a cause of secondary hypertension. What is more prevalent in your day-to-day practice?
So by far hypothyroidism is much more prevalent, though if you try to find out the chances of hypertension,
Yes.
the percentage of patients who are hypothyroid comes to you with hypertension is actually lower compared to the hyperthyroid group. But as the hypothyroid is far more prevalent compared to hyperthyroid, so you'll get a patient of high blood pressure. More likely, if it is thyroid-related disorder, it is hypothyroid.
Okay. Any question?
Obstructive sleep apnea, you
Yes,
have
sir.
told that CPAP therapy will not reduce mortality.
No, sir.
But I have seen so many patients who are hypertensive on CPAP, their antihypertensive medicines came down. And one of the patient, I have to withdraw antihypertensive medicine after CPAP therapy.
Yes.
And few patients who were prescribed CPAP, of course, they died in sleep. But I don't know the cause, exact cause, what was the cause. But during hypoxia, there can be ventricular fibrillation.
Yes,
or like
this
that.
is directly related to the mortality. Chance of sudden cardiac death will be elevated if the patient is having obstructive sleep apnea. But the problems are here, we do not have evidence. That means this is a data-free zone. If you ask me whether if I apply CPAP therapy to a patient who is having established severe obstructive sleep apnea, whether that will improve the survival of the patient, I don't have any answer because none of the trial has shown us. But if something which is very effective in controlling the blood pressure, at least blood pressure related effect will be weaned off. But as of now, we do not have any randomized control trial which suggests that using CPAP reduces the chances of sudden cardiac death. We can't say that. But from secondary analysis we can add, probably it helps.
What is your personal feeling?
I do use CPAP to all my patients who was diagnosed with severe obstructive sleep apnea, and also lifestyle modification. Also, I also use SGLT2 inhibitor in this group of patients. There had been a trial with Jardians which has showed clearly that obstructive sleep apnea patient may be benefited from Jardians, I mean the empagliflozin therapy.
Yes, yes.
But I do use.
We are winding up the session, a very beautiful session, and for photograph.
Thank you so much,
whatever you
Speaker.
want.
Thank you,
Please.
Chairperson. I would like to request all the chairperson to please facilitate our eminent speaker. Thank you. Thank you so much.